2408th meeting. Yeah, it's on. Is it on now?
Yes. Yep.
I now call to order the Society's 2408th meeting in the 149th year since its founding on March 13th, 1871. Good evening, everyone.
Good evening.
My name is Larry Milstein. I'm the president of PSW, one of the oldest scientific societies of Washington, D.C., committed to providing a forum to further scientific understanding and inquiry. Welcome to our guests to tonight's lecture by Kim Janda in the John Wesley Powell Auditorium of the Cosmos Club in Washington, D.C., including our members and friends around the world who are watching the live stream of tonight's meeting on PSW Science's YouTube channel. We will begin with a few announcements and a reading of the minutes of the 2407th meeting and the lecture on Understanding Dark Matter by Mary Angela Lasante. We will then turn to this evening's lecture, followed by a question and answer period. Thereafter, I will present a small thank you gift to our speaker, make a few closing announcements, and adjourn the meeting to the social hour. But first, please join me in thanking the sponsors of the 2018-2019 lecture series, the Policy Studies Organization in cooperation with the American Public University, and a generous donor who was asked to remain anonymous. I am pleased to announce that the following new members have been elected to the Society. Warren Hearn, a physician and public health epidemiologist interested in fertility, women's health, and related issues, who comes to PSW through his friend, PSW speaker member Compton Tucker. David Stokes, an engineer with DoD, interested in human impacts on the environment, astronomy, and space exploration, who comes to PSW through a member of the Northern Virginia Astronomy Club, also known as NOVAC. Catherine Gansler, a student of planetary sciences at the University of Maryland, interested in the history of science, engineering and astronomy, who comes to PSW through Ann McQueen's post on the NOVAC Facebook page. Teresa Pezzi, an event organizer interested in behavioral studies, psychology, and chemistry, who comes to PSW through PSW member Tobin Kozier. Marvin Stodolsky, a molecular biologist retired from the Department of Energy, interested in large-scale genomics projects and cosmology, who comes to PSW through the PSW YouTube channel. Lloyd Franklin, an aerospace engineer with Boeing, interested in particle physics, planetary science, astrophysics, cosmology, and space exploration, who learned of PSW through, quote, great lectures offered to the public, close quote. And tonight's speaker, Kim Janda, whose background and interests will be clear to you at least a little bit from tonight's proceedings. Please join me in welcoming them to membership. All new members receive a signed copy of Volume 1 of the Bulletin of the Philosophical Society of Washington, covering the period from March 1871, when it was founded, to June 1874, including the address of the first president explaining its founding and its name. I commend this copy to all of you, and if you are interested as a new member and have not received your copy, please see me after the lecture. Social Media Director Ann McQueen, filling in for Recording Secretary James Heelan, who is traveling, will now read the minutes of the 2407th meeting and the lecture by Mary Angela Lasante on Understanding Dark Matter, the Mystery of the Missing Mass, delivered here at the Cosmos Club on April 12, 2019.
Good evening. On April 12, 2019, in the John Wesley Powell Auditorium of the Cosmos Club in Washington, D.C., President Larry Milstein called the 2,407th meeting of the Society to order at 8:01 p.m. He announced the order of business, that the evening's lecture would be live-streamed on the internet, and welcomed new members to the Society. President Milstein then introduced the speaker for the evening, Mariangela Lasanti, Assistant Professor of Physics at Princeton University. Her lecture was titled, Understanding Dark Matter, Archaeology of the Milky Way, The Mystery of Invisible Mass. Lasanti said scientists can use the gravitational effects of an object to infer its presence. She then explained that scientists should be able to predict a star's speed around the center of the Milky Way. Newtonian gravity dictates that orbital speed is based upon the mass being orbited decreasing when the enclosed mass decreases and when separation increases. However, the galaxy is rotating much faster near its outskirts than expected from Newton's laws. There are two possible solutions to this problem. First, that Newton's laws are flawed. To modify those laws to fit the observed galaxy, visible matter must be able to source accelerations greater than Newton predicted. But reproducing flat rotation curves overpredicts the vertical velocity of stars. This hypothetical solution is thus likely incorrect. The second solution is that there is a mass in the galaxy that scientists cannot see. This unseen mass is dark matter. Lasanti said the galaxy is within a halo of dark matter, extending 10 times the diameter of the visible galaxy, moving with the same average speed as the galaxy's edge. Absent data, scientists assume the dark matter halo is smoothly distributed and has no preferred direction or motion and therefore does not lose significant energy. Lasanti then explained that scientists believe, while rare, dark matter collisions with visible mass can be detected. A variety of detectors are currently being tested around the world. One such detector is a large tank of liquid xenon placed under a mountain in Italy, designed to detect the movement created by dark matter collision with a xenon nucleus. One way dark matter may react with the nucleus is through the Higgs boson, recently discovered by the Large Hadron Collider. Dark matter may exchange a Higgs boson with a quark, causing the quark matter to recoil off the nucleus. By observing a nucleus at rest that then moves, scientists will indirectly detect dark matter. Lasanti said dark matter detection rate will increase if there are more dark matter particles flying nearby and if the dark matter is moving at a faster speed. To make accurate predictions for experiments, Lasanti said scientists must resolve their assumptions about the dark matter halo around the Milky Way. To create an accurate dark matter map, scientists must understand that the galaxy formed when small galaxies combined and then trapped and incorporated other nearby galaxies. Lasanti said scientists can then rewind the incorporation process to create the Milky Way's family tree by examining stellar positions, velocities, and chemical properties. From the L2 Lagrange, the European Space Agency's Gaia satellite repeatedly mapped star locations to identify their motions. So far, the Gaia satellite has gathered sufficient data to infer 7 billion years of the galaxy's cosmic genealogy, showing multiple streams of galaxies both recently incorporated and currently being incorporated into the Milky Way. By observing perturbations in these streams, scientists can infer the tracks of dark matter clumps or subhalos that pass through. In 2018, scientists published the first potential evidence of a dark matter subhalo by identifying similarities between the observed GD1 stream to the model of a perturbed GD1 stream. Lasanti's team has been studying the galaxy identified as donating the majority of the stars in the inner part of the Milky Way. By measuring these stars, Lasanti believes she can conclude how fast the donor galaxy's dark matter is moving. In sum, these conclusions, and those that follow, will lead to a more accurate map of the dark matter in the Milky Way, which will allow scientists to create better dark matter detectors. A guest asked how scientists will be able to distinguish a dark matter collision from a neutrino collision. Lasanti said neutrinos are a type of dark matter calculated to be a small fraction of the total dark matter and are thus unlikely to comprise all dark matter collisions. A member asked, if the dark matter background signal is greater than the neutrino background signal, why we have not yet measured the dark matter background. Lasanti said that scientists have not yet detected the neutrino background and that she predicts scientists will determine the neutrino background signal is equal to that of dark matter. After the question and answer period, President Milstein thanked the speaker, made the usual housekeeping announcements, and invited guests to join the society. At 9:55 p.m., President Milstein adjourned the meeting to the social hour. Temperature, 21 Celsius. Weather, cloudy. Attendance in the Powell Auditorium, 200. Viewing through the live stream on the PSW YouTube channel, 46. Respectfully submitted on behalf of James Heelan, Recording Secretary.
Thank you, Ann. Are there any comments, corrections, questions on the minutes? Hearing none, I will entertain a motion to accept the minutes as read. Do I have a second from a member? All members in favor? All members opposed? The minutes are accepted as read and will be posted to the website in due course. And we now turn to tonight's lecture on vaccines to combat the opioid epidemic. It's my pleasure to introduce tonight's speaker, Kim Janda. Kim is at the Scripps Research Institute in La Jolla, where he is Callaway Professor in the departments of Chemistry, Immunology, and Microbial Science, and where he also is Director of the Worm Institute of Research and Medicine. Early in his career, Kim showed how antibodies can be transformed into dynamic chemical catalysts, commonly referred to as catalytic antibodies. He developed synthetic methods for making chemical and biochemical diversity libraries, including phage display and small molecule DNA encoding methods. Along the way, he also developed an inexpensive diagnostic test for river blindness, based on his discovery of a small molecule neurotransmitter unique to the disease. More recently, he's been pursuing a new approach for treating drug addiction by harnessing the immune system to reject drugs of abuse in much the same way it deals with agents of infectious disease. He's an author on more than 600 peer-reviewed papers and has delivered more than 350 invited lectures. Among many other awards, he is the recipient of the American Chemical Society's Alfred Bader Award in Inorganic and Bioorganic Chemistry, the Cope Scholars Award, an honorary doctorate from the University of Helsinki, Finland, and he is a AAAS Fellow. His work has been reported frequently in the media, including Discover Magazine, The New Yorker, The Economist, Wired, The New York Times, and numerous other news outlets. He earned a BS in clinical chemistry at the University of South Florida and a PhD in chemistry at the University of Arizona. Please hold questions for the question and answer period at the end of the lecture. And join me in welcoming Kim to the podium.
Okay. Thank you. Well, good evening. Many don't know, me and Larry go way back, way back. But he's a lot older than me, but we still go way back. I've known Larry, I think, 35 years at Scripps. He was the first graduate student probably at Scripps, right? That's considered. And when I came to Scripps, I shared a lab with him. I was basically the first chemist there, where I was an organic chemist. And we didn't have fume hoods back then. We were still in the process of putting them in. And I needed to do my work, so I set him up on the bench top. And yeah, that caused some problems at times. One of the group members of Larry's, her name was Wanda Reynolds, used to always come up to me and she'd say, "What is that smell?" And I'd say, "What smell? What?" And she goes, "That smell." What? Can you define the smell, Wanda? And she'd get really angry, and she had a very high-pitched voice. I can't even, and she'd go, "What is that smell?" And I'd say to her, "This apocalypse now, that's the smell of victory, Wanda, and we got to just move on." So with that, we'll push forward. So hopefully I'll get through all these pieces. I kind of want to define what we have, and I'm going to show a lot of data, and the reason I show a lot of data is hopefully you'll believe what we're doing is true, but I'm going to just gloss over it. So if you fall off at any time, this will be kind of the order that I'll go through in describing what I'm doing. So that's the agenda. So a little bit about vaccines. I mean, if you haven't seen them, they've been in the news extensively now. We've seen these huge comebacks of measles, and you're going to see polio coming back now. And it's a real shame because people have gotten this fear that vaccines are a problem. Vaccines have been around since 1000. Chinese employed virulation. Basically, they take these dried pustules and sniff them. It's kind of like inhalation type now with a lot of vaccines. First probably real vaccine was Edward Jenner, or smallpox, the cow, treating the young boy with material from the cow. It's considered the father of vaccinology. But the really first vaccine in the lab was done by Pasteur. Most people probably don't recognize him for that. Actually, it was kind of by accident. Pasteur was working on a vaccine for anthrax. I think it was anthrax, I believe that was the time. And he had a technician left the material out in the bench top. And of course, in France, you go on vacations for several weeks. And so when they came back, the material was attenuated. And so that's how that came about in terms of vaccines, was by chance during that. We still use alum. I'd say 95% of all vaccines in the US still have alum. It's an adjuvant. And that's back in the 20s it came about. Probably a person that people have never heard of, but they should. This guy probably should have won a Nobel Prize, Hillman. He's developed some 8 to 10 vaccines when he was at Merck. Measles and mumps were some of them, but he was kind of unknown. And then maybe kind of dating Eddie Cantor and so-called March of Dimes got started, where he said, send your dimes into President Roosevelt. Millions and millions of dimes came in, and that's how the start of the March of Dimes came about. Okay, so in developing these vaccines, our body doesn't recognize a drug as foreign. We have to somehow make it do that. And so there's 3 key aspects. One's the hapten, the other one's a carrier protein, so it's what's called the T-cell epitope, and the other thing is the adjuvant. And if you kind of miss on any one of these 3 things, you don't make a very good vaccine. So that's key to hit all 3 points. So we'll be talking a lot about hapten. So the hapten is going to mirror the drug as closely as possible, or some form of the drug that we're going to make the antibodies to. We don't want to have the antibodies made to off targets of the drug, because that way they won't be able to sequester it and keep it going from its target. We'll talk a lot about titers. So a titer is how much antibody is being made to the drug. It's not a great metric, but it's something that we do use in terms of measuring how good a vaccine is. One of the things that is key is in terms of the hapten is the chemical structure that we're going to use to make this. So whereas in typical vaccines, like if you vaccines to a virus or a piece of bacteria, you have so-called epitopes, and we don't really have epitopes here, so I call them chemical epitopes because they're very small, and so it's very important that we keep everything intact. And a lot of these drugs have stereochemical centers, and it's important to try to keep those in place, because you don't want to have your antibodies recognizing the wrong form of the drug. That's critical. So, and in terms of making the vaccine, we have what's called the linker. So we don't just take a drug and throw it in there. We have to somehow conjugate it to the carrier protein to do this. So the linker length is important. How many copies of that hapten's on is important. And I always like to say it's something like Goldilocks and the 3 bears. Not too many, not too much, just right. The porridge has to be just right. And I can't tell you which is the best one, but about between 4 and 8 atoms seems to be pretty good. Okay, so let's look at some of the immunology here. So typically when we formulate this vaccine, vaccinating rodent or non-human primate in humans, it gets taken up by what's called dendritic cells. It's then going to get displayed onto the major histocompatibility region, and this allows T helper cells to come into play. And these will then activate B cells, and then once the B cells are activated, hopefully we can generate consistent neutralizing antibodies to the drug. Okay, so that's a more intellectual version. The simpler version is basically we're going to make antibodies. Antibodies don't cross the blood-brain barrier. The drug wants to get to the receptors in the brain. The antibodies basically block the drug from getting to the brain. In other terms, if the antibody has strong enough affinity for the drug, it can actually act as a vacuum to pull the drug out of the brain. So there's two ways this can actually work in terms of design. So this is a simplified version of how these things work in a manner. I had a slide in here, and Larry, I was livid about this. He said you had to take it out. So I had a trailer in here from the Fantastic Voyage. And so most people remember the Fantastic Voyage. This is, for me as a boy, it was my first scientific movie I ever went to. It was 1966. Starred Raquel Welch and Stephen Boyd. And he said, we can't use it because of YouTube. I said, but we didn't copy this YouTube. This was years ago, one of my students, we sat in front of the TV when the movie came on, and we had a camera, and we filmed this little segment where Raquel Welch is being attacked by antibodies. She alerted the immune system. And the reason why I show this is because one of my former graduate students' mother was good friends with Raquel Welch. They went to church together. So she told Raquel that I used this trailer in my talks. And so for my 50th birthday, I got a signed copy of that from Raquel Welch, the trailer of that. It said, "Love and kisses to Kim." And so that's hung predominantly in my office there. That's one of my important rewards there. In any event, so that's what I was going to show, but we couldn't because Larry said the site would get closed down and we'd be in big trouble, so I had to explain it to you. There we go. So they can come after me on that. All right, so these are what the antibodies really look like here, or these are crystallographic structures. So this is what's the typical foot soldier, the IgG, which is going to come in and basically remove the drug. There's simpler versions, what's called Fab and single chains, which are the areas where binding takes place, but they're all very similar. It's just different manifolds, and these manifolds have different half-lives, but they work in a similar manner. Okay, so I don't just do opioids. I've worked over the years on a number of different drugs from, from nicotine over here to cocaine, opioids, and then methamphetamine. So there's an exam afterwards. You have to pick out the meth lab in this one. Okay, you picked it up already. Great. Well, we're moving ahead tonight, Friday night. All right. Okay, so opioids can be defined in three areas. I like to put them: natural, semi-synthetic, and synthetic, and we'll hit pretty much on all of them. I'm not going to, actually, we won't hit on the natural. We'll talk morphine is from heroin, but I'm not going to talk to you about mitragynine. If people are interested, we can talk about that later. I know people think that's going to be a cure, but we've worked on it. I don't buy into it, but we're going to hit on most of the things here. Some of the first, known, I guess, true drug for this was, actually I gave a lecture at Bayer and showed this slide, and they weren't too happy about this, but they actually sold this as for relief of coughs. If you look very closely down here, it probably can relieve any type of cough you have in there. Anyway, so yeah, that's in there. And so then we go, the whole thing is going from the poppy to heroin. And so Larry said there's no questions, but I'm going to pose this question to see if anybody asks. Why do people take heroin? Why not just take morphine? Huh? Well, yes, but there's a another reason why. Why? What? Nope. Heroin has absolutely no affinity for the mu-opioid receptors. It's not a drug. Heroin's not a drug. That's a misconception. It's a pro-drug. Heroin crosses the blood-brain barrier very quickly. So what happens is these acetyl groups on here allow it to cross the blood-brain barrier quickly. Morphine crosses very slowly. So that's why you use heroin. Heroin then degrades in the brain to what grows to 6-acetylmorphine, which is one of these released, and that has affinity for mu receptors, and then morphine has affinity. That's all. That's the reason why. It gets across the blood-brain barrier quicker. That's it. It's a good test question for grad students. Okay, so why are we doing these vaccines? There's medications out there, and there's nothing wrong with those things. There's so-called substitution therapy. There's antagonist drugs. So naltrexone, I'm sure people have heard of before. I'm sure everyone's heard of things like buprenorphine and methadone clinics. And there's obviously cognitive therapy. But the reason I'm talking about this, if these really worked well, then we wouldn't have to rely on trying to come up with something else. I think of the vaccines, the usefulness will be in the following, that it won't require daily compliance. That's one. We hope it'll normalize the individual. It should reduce risk of overdose. You shouldn't have such side effects. A number of these things have a number of side effects, and people don't like taking them if you're having side effects. Vaccines are very inexpensive. I mean, vaccines are the #1 therapeutics that are used in third world countries. They've saved more lives than any drug out there. They're very inexpensive to make. We don't think you should be able to have illicit diversion of other opioids. As I say, they're scalable, and the third world option. So the reason why I got involved in doing these vaccines, I was doing other drugs of abuse, was because a number of years ago I looked at a spike in HIV where in third world countries, injectable needle users were sharing them. And so I thought this could be value here, not for the US. This was actually going to be exposing third world countries where I thought it could make a difference. Okay, so here's the pharmacokinetics. So like I said, heroin is here. It's got a very short half-life. It then goes to 6-acetylmorphine, which then has mu-opioid receptor agonist ability, and then finally the morphine. So heroin is a moving target. You're going from this to this to this. So the question is, what are we going to make antibodies to? Are we going to make it to heroin? Are we going to make it to 6-acetylmorphine or morphine? And so what I thought is, let's try to make it to all of them. So we're going to use a hapten that's going to slowly degrade and let the immune system sample each one of these pieces. And so that's what this is called, this heroin hapten, like here. And we're going to test this hypothesis out with something that's just a morphine hapten, so it doesn't have those 2 acetyls that can degrade. So it's Friday night. I'm showing a lot of organic chemistry, so we'll just show you some organic chemistry. We make this in the lab. I don't just go down and we order it from somewhere. We synthesize these things. We think about these things, how to make it. So it's not trivial in making these guys. Okay, so the design, let's kind of go back and summarize. So we got a drug. We want to make antibodies to it, so we're going to do some synthetic chemistry on it. We're going to put a linker. We're going to attach it to a carrier protein. This is going to then allow us to formulate it with an adjuvant. We're going to then vaccinate initially rodents and hopefully humans, and then we're going to make antibodies to this, and those things are hopefully going to sequester the drug. So we have to test this out. There's different ways you can test out for opioids. You can do such things as antinociception, so pain, other things as respiratory, but I'll just talk to you mainly tonight about pain. So one of the things we use is what's called a hot plate test. You put them on the hot plate, and what happens is the rodent, when it feels too hot, it picks its back paw up, and then you measure that for a period of time. We also do a tail flick where you put it in hot water and they'll flick it out. So those are 2 of the ways we can measure it. Do another thing called von Frey's test where you put a little metal bar and push it up on them. When they pick their paw off, you measure how far it goes up in the pressure and the time. But what you can see here, the key aspects is that this heroin vaccine, which degrades the HER, is much better than any other so-called static vaccines. So that's key here. We do more sophisticated studies. We put them in operant boxes. Basically, what we do is we train the animals with a catheter going in, either getting infused saline or food or drug, to press a lever. And these levers are typically, get this thing, these levers can be cued with a light that goes on or a sound. And so this gives them the stereotypy type. So that's a cue for them. And so what they do is they'll press the lever, and they learn to press it for drug or food and whatever, and they'll press for periods of time. And this is the infusion we give them. And so this is actually what it looks like, and they'll press away, and actually, depending on how long you go, they look really bad, can be really strung out, these animals. So it's a pretty good model for this. It takes a long time to set up. This takes a couple months to set up, so it's quite time involved. So basically what we see is what we do is we train them to press this lever and they become addicted to heroin. And then we take them off heroin, we cold turkey them, and we vaccinate them for about a month. And so then we put them back on, and you can see what happens is they start escalating, they start taking more heroin. But with the vaccine, if we have cues, they become static, and no cues, they basically drop off. And these cues are basically trying to mimic human behavior. So people who are undergoing cessation type therapy or stuff, they don't just typically go out and do the drug. They may smell something, they may hear a song, they may be talking to someone, you know, and go out, take the drug, right? And so that's kind of how these cues are supposed to be set up. So one of the questions I usually get is, well, you know what? Someone will just take more drug. They'll surmount the amount of antibody you have there. They'll just load more and more drug on. And we've seen this in some cases with things like nicotine, that the animals will surpass the amount of antibody we have that can remove the drug. But we don't see this with heroin, so we see it much less here in terms of the control. So we don't see them taking more drug on. So what this progressive ratio is, they press a lever and they have to work harder and harder for drugs. So it's 1, 1, 2, 2, 3, 3, 4, 4, 5, 5. Sometimes they'll press this thing 100 times. They want the drug so bad. Okay, so I'm going to hopefully show you a little video where we give one of the animals 2 mg per kg of heroin. We give the other one 18 mg per kg, but the vaccine. So you see the one, hopefully you'll be able to pick the difference between the two out. Let's see if hopefully this plays. So that guy moving around's got 18 mg per kg in the vaccine. The other guy only got 2 mg. He's kind of sleeping in the corner there. So the other guy's happy, he's a little clammy. In fact, he wants to get out. Okay. Okay, so it looks pretty good. We developed this vaccine, it works pretty well, but we wanted to make this thing hopefully what I call bulletproof, so it would really work well, because there's different, when you vaccinate individuals, everyone's different, and so different people could have different responses, and so we thought we'd try to improve it as best as we can. So what we did was we tried to improve the adjuvant. We used what's called CpG, it's a TLR9, to try to bump up the overall effects. And you can see here that we go from what was the original stuff about 2 to 10-fold better. And we've increased this now by changing the hapten a little bit. I won't show you the structure. And we've basically changed the carrier protein. Now we can make this thing about 30 times greater than the original vaccine you saw with that one animal. They got 18 mg per kg, so a much better vaccine. One of the things is stability. And so most people probably aren't aware, probably don't care that much about, but typical vaccines you have to keep cold. You transport cold. You know, you go to the doctor's office, they're not warm, they're cold. If you're in a third world country, let's say you're in Africa, it's called the cold chain. How are you going to beat the cold chain? You got to take it out to people, you know, it's warm weather. So we actually came up with a way that you can actually formulate the vaccine and lyophilize it, so we make it a powder, and so you'd reconstitute it at that time, so it should have stability. And we looked at that, and what I did at the end of the day, because we had some animals left over, we did an overdose study, and it actually worked reasonably well. So we saw that the vaccine actually did protect against lethality. Now, I don't recommend this vaccine. I'll talk to you a little bit later tonight about how we think individual monoclonal antibodies would be better for overdose, but this did have some effect, so that was important. We've moved on and done some non-human primates. This was done with Matt Banks and Steve Nikas at VCU, and you can see it works really well. We see a similar dose in terms of 10-fold shift in comparison to naltrexone, which I talked to you a little bit earlier about. And we've looked closely why it works well, and why it works well is because it binds very tightly to the drug. And it doesn't bind to other drugs. So you can actually use, this is actually people say, well, what if I wanted to take another, you know, possible opioid for a problem? This vaccine will only hit heroin. It doesn't hit any of the other things. Very specific for heroin. So just to kind of recapitulate, what I've showed you is you know, we can look at this drug, we can create a vaccine against it, and it's based on how much antibody titers and how tightly it binds to it, and basically what it does is it blocks the drug from reaching the receptors in the brain. That's pretty much it in a nutshell. We've also looked at this, so once we had success there, we decided to look at a prescription opioid, which we've heard a lot about, oxycodone and hydrocodone. And so I'll go through this quickly. It's basically a similar scenario that we can use, that we're going to, again, take a structure that's going to be very similar to these two drugs. We're going to attach it to a carrier protein, throw an adjuvant in there, and vaccinate. Now, the structures between oxycodone and hydrocodone are very close. So in terms of this vaccine, we weren't able to make it which could recognize one or the other, but I don't think that's a big problem here. So all this slide shows you is looking at antibodies is we see crossover. So the vaccine to hydrocodone binds oxycodone, the vaccine to oxycodone binds hydrocodone. And okay, so one of the things though that we saw was, which really quite interesting, was the following, is that, so, you know, these antibodies sequester the drug. Well, what happens to the drug? Well, eventually it's degraded, but it changes the pharmacokinetics of the drug. So typical half-life of these drugs is 20, 30 minutes. But with these antibodies around, it makes them half-life extended to like 200 hours. So it really sequesters them and holds on to that and slowly just kind of degrades it. And I bring this into play because Pfizer was working on a nicotine vaccine, and they made this claim how their vaccine increased the half-life from a couple hours to 7 hours. And like you can see here, between ours, it increased it just dramatically greater in terms of that. You know, so hugely different. We've changed the pharmacokinetics. And as you might suspect, there's no selectivity here, so the oxy hits either one of those. And so again, we looked at the hot plate and tail flick in terms of measuring these things, in terms of the vaccine's efficacy. And then we also looked at an overdose scenario. It worked, but it didn't work so well. So I think, again, I'll talk to you about monoclonal antibodies later. That's probably a better scenario in terms of working and developing an immune approach for treating overdose. Okay, so I'm done with the heroin part. I'm going to talk to you about synthetic opioids now. And again, I got involved in this before there was this epidemic that was out there that we heard about. We've been working on this several years. And it wasn't like I was a savant for, you know, vaccines and drugs of abuse. I was just more or less interested because the potencies of these synthetic opioids were so great. I wondered if the immune system would have a chance to block this. So that's the only reason I kind of got involved in that, was that I had some intuition that this was going to be a problem. So these synthetic opioids, I'm sure you heard of. Fentanyl is the darling of them all. It's a Schedule II. It's been around a long time. Janssen Pharmaceuticals has made this, Paul Janssen, back in the 60s. Let me go back. So key players, these are all approved drugs, are fentanyl, L-fentanyl, sufentanil, low-fentanyl, carfentanil. Carfentanil is not approved for humans. Carfentanil is used for, you know, taking down rhinoceroses or bears or stuff. It's extremely potent. And that's the problem why this stuff is creeping in. A lot of people are dying because of these extreme potencies of these synthetic ones. So, you know, people always ask, well, why are you using synthetic opioids now? Why not just heroin? So it's based really on economics, the drug dealer economics. Most people who are addicts will go to find the best high. So where people are dying, that's where they'll go. They want to look for the best high. And in terms of getting the best high, when heroin becomes impure, you put synthetic opioids in because it's cheap to make. So it's an economic thing, simple as that. And that's how it's kind of got put in there. And it's very simple to make fentanyl. You can make it in 3 steps. You can make enough to, you know, it's very easy to make. The other point that I want to make is that because it's so easy to make, and there's many, many different derivatives out there. So such things you've heard of as China white, acetyl fentanyl. So this was a problem that several years ago, I think it was Rhode Island, hundreds of people died, and they couldn't trace it back because what happens is if you make certain small changes in the structure, the people who are trying to identify it can't do it easily by means they're doing it. So that's why a lot of the drug dealers are using these things. So small perturbations in the molecule still keep it very potent. Okay, so one of the questions is why are these synthetic opioids so powerful? Well, one of the things is they do bind very tightly to their receptor, the mu-opioid receptors. The other thing is they quickly transfer out of the plasma to the brain. So you look here, morphine is really slow, right? But fentanyl is minutes, alfentanil, remifentanil, very short time. So they get in there very quickly. Okay, so if we want to devise a vaccine against it, again, we look at its overall metabolism. I don't want to make the antibodies to attack, something that's not important or not psychoactive. And so we look at this in terms of the design. And fentanyl is actually pretty stable, and so we don't have to worry about any of the off-targets like I have to with heroin. And so what we did was some molecular modeling and trying to design something, in this case, where I made a very specific heroin vaccine. I was kind of thinking ahead. If we're going to develop a vaccine against fentanyl, we want to make it pan. We want to keep one step ahead of these so-called clandestine labs. And so this vaccine I have now will hit like 9 or 10 of the different fentanyls out there. So that's just showing some of the ones here, and that's the overall design. This is how we do it. So again, we vaccinate 2 weeks, 4 weeks, and then we challenge them with the drug. Again, doing the anti-nociception tests. We also measure binding, and then sometimes we do look at the blood-brain barrier. So we sacrifice the animals to look at how much drug's in the brain versus how much is outside of it. And so, as I told you, one of the reasons we got into this is because I wanted to really test the system, and I was really worried about this. But you can see here, we see huge shifts in terms of the potency, 33-fold. So this works really, really well, much better than the heroin vaccine. So this was kind of surprising to me, but that's the data. And again, this is looking at how much drug is in the brain, and you can see extremely small amounts of drug get in the brain with the fentanyl vaccine. And again, the reason why is not just we have antibodies, but they're very tightly binding. So these things bind like sub-nanomolar to the drug. So that's one of the reasons why it works so well. And in this case here, they work pretty good for overdose. So we tested a number of the animals here, and basically all of them survived. Okay, so now I want to talk to you about specific singular antibodies and more use in terms of overdose. And so on this slide here, again, I'm showing you the overall potency. So morphine, heroin, which is the same, it's 2, but fentanyl, and then carfentanil. Carfentanil is extremely potent, 10,000 times more potent than that. The reason why we want to look at this with antibodies is that you could say, well, if you have an overdose from these synthetic opioids, it's well known, you take naloxone, Narcan, right? There's a downfall with Narcan. Narcan, how it works is it basically comes in there and kind of brushes it off the receptor, moves the drug off the receptor. But naloxone has a shortcoming, it has a short half-life, and whereas these synthetic opioids sit in the fat tissue, they come out and basically you get a rebound effect. And so what you have to do if you find some of these synthetic ones, you have to keep them in the hospital long periods of time, or you give them a drip of naloxone. And so that's issues. I think we could just give an antibody, you could send someone home at that point. So that's our goal here. Okay, here's the structures again. So we first went about making, I'll tell you how we made human antibodies, but we made just simple rodent antibodies to test the overall hypothesis out. So this is how we went about it. And then what I'm going to show you here is the success here. So this singular antibody shown here, which by these different titles, 2F12, 6A4, 7A8, they bind all these different fentanyl drugs, some extremely tight, some not so tight, but you can see they cross over quite well. We looked at the 6A, here's several of them. So one of the questions you might ask is, what's driving the binding affinity? And so if you cluster these things together, they all pretty much come in terms of the antibody latching on the drug, they're all pretty much the same. So how quickly the drug comes onto it, it's diffusion limited, it's pretty much the same. But what we see, the differences come in terms of off rate. So when the antibody and the drug come together, how slowly it comes off the drug. That's the key here. And so you can see here when we measure this, in this case here, this antibody 788, the carfentanil, you can see the drug is slowly coming off the sensogram, where in this case over here, this antibody binds fentanyl so tightly it's not letting it go. It's just holding on to it. So we did more sophisticated binding measurements, and so here you can see some of the binding constants. And again, these things bind in the areas of sub-picomolar level, which for small molecules, an antibody to what I call small molecule drug is pretty much unheard of. We did some pharmacokinetics on one of the better antibodies we call 6A4. And as I told you before, one of the things it does, it really changes the half-life of the drug, extends it greatly. And these are measured in different pharmacokinetic parameters shown here. So then looking to see if it's going to have value in terms of not just fentanyl, carfentanil, we dosed this particular antibody. And as you might expect, as you put more antibody in, we got better effects in terms of the ED50, again, looking at the hot plate and tail flick. And then it's kind of hard to see in this, but so just trust me on this. What we did was we gave the animals the drug. We waited for 15 minutes, and we gave the antibody, and we gave naloxone. And what we saw is after a period of time, you do see a slow rebound with naloxone, but with the antibody, you don't. And we couldn't take this out further because the drug just wears off. So the premise that the antibody will stay on longer periods of time and block it is there, whereas with naloxone, it rebounds back. Okay, so hopefully you believe me that we have vaccines that work pretty well. I can show you how we can make rodent antibodies, but it's not good to put a rodent antibody in a human because you're going to get an immune response from that. So that's in the wrong case. We don't want it to the antibody. So we went off and we decided to make human antibodies. And so what we did to do this, we looked at a transgenic rat. It's called an omni-rat. So if you have transgenic models, you have to come up with cool names. Omni-rat seems like a cool name. And so there's a company that sells these guys. And so what this does is it produces human antibodies, but it has a rat receptor, and then we can remove that part off on the FC part. So this is kind of a busy slide, but this takes a lot of work. So what we do is we make the vaccine, we vaccinate the rats. We then, I'll show you, create these fluorescent probes that allow us to pull B cells out. We single sort these B cells. We select these B cells. We clone them up. We look for binding affinity. We then fully humanize them. We then go back and test these in small rodents. If that looks positive, then we then go off and I'm sorry, let me move back. We then go back and we'll hopefully test this in non-human primates. So here's some of the probes. Again, it's Friday night, and we don't want to bore you with all the organic chemistry, but it's complicated making these probes. The key aspect is that it allows binding and to be coupled with a fluorophore, which I show on this slide. So what we do is we're able to take biotin, which binds to streptavidin. We have different fluorophores on streptavidin, and so we're able to use a sorting machine, which then can select out the highest binding affinity antibodies to the drug, which you can't see on this slide, so you have to take my word for it. So what we do is we pull out hundreds of thousands of clones from this, and there's a small sampling, but we pick out ones that specifically bind fentanyl, specifically bind carfentanil, some that have broad cross-reactivity to all these, some that don't bind anything, and then so what we do from that is we pick selected clones. And so in this case here, using this selection process, we can get extremely exquisite binding here. So this is, sub-picomolar binding. So that I'm only 30 years in making antibodies. This is some of the tightest binding antibodies we've ever seen. And we're going to show you, we need this because of the affinity of this drug for the receptor. Again, going back, it's just Le Chatelier's principle. If the drug has greater affinity to the receptor than the antibody has to that, it's not going to pull the thing out. It's going to go for it. So you have to have that in there. That's critical. And so we have this one antibody called 1A4. It's now fully humanized. Its potency to carfentanil is shown here. And you can see here how we're low picomolar binding affinity. Half-life is about 4 to 6 days, and it shifts the dose response 36-fold. Remember I told you that fentanyl vaccine was 30-fold? So this is 36-fold. This is really impressive. Okay, so just want to finish up a little bit. I think that's it on those guys. On a problem now, which is creeping up, is heroin contaminated with fentanyl. As I told you, when people want to get the best high, heroin's not as potent as it should be, or the costs go up, fentanyl gets put in. And there was an interesting study came out of NIDA where they showed this effect where fentanyl and heroin together didn't give each 1 + 1 additive. It actually boosted it up higher. And we'll have to look into this more closely, but it's kind of interesting. But it definitely is more potent when you mix these two together. I kind of put this in because this is in Chemical Engineering News, and I kind of like this. Any dealer that's worth its salt are not going to have 50 to 20% fentanyl in their product. It will kill everybody. So they know, they're smart enough that you want to have the best high you can, but not kill people off. Okay, so what we did was, it's nothing really clever. I've developed this heroin vaccine. I developed this fentanyl vaccine. We're just going to mix them together and vaccinate the animal, and hopefully we'll get antibodies to both structures. That's the whole key in a nutshell. And what I show you in the next slide is a lot of data, but trust me on this. You know, we tried the fentanyl vaccine alone, the heroin vaccine alone, and you get antibodies to individual heroin or fentanyl, but they don't cross. And if you use the mixture of the two, the combo, you get antibodies to both, which you expect. And as you expect, the combo works against both drugs, and the non-combo only works against one of the two drugs. So that's exactly what we're hoping to see. So what we hopefully planning going forward. Originally, we were just going to go forward with the heroin vaccine, but I think this is probably just not the best thing to do. We're probably going to try to do a combo vaccine of heroin and fentanyl together. And this slide, again, shows you here where we just look at how much drug's in the brain, and so the combo will work better than each individual ones alone. So I got a couple minutes left. I'll just, this off the side hook, but put it in. So I kind of like to call this, it's immunopharmacotherapy. It's a term I coined like 25 years ago, because when as assistant professor starting out, you have to come up with your own terminology, or otherwise you're not going to get recognized. So you have to come up with something, right? You know, I want to not talk a little bit of a different immunopharmacotherapy, but in this case, because we're not using immunology, it's really just a biologic. And for a number of years, I tried to make a nicotine vaccine, and there's a number of companies that tried to do this. And the reason why people went out and put money behind the nicotine vaccines is because healthcare covers people who smoke. You know, healthcare doesn't typically cover heroin addicts. So, and what I'll show you here is the number of companies that have tried to make nicotine vaccines and have failed. And this is just a small sampling. There's way more than this. So I don't have my name in here because mine didn't get into phase clinical trials. We didn't get that far along. So I didn't make this see a failure. But I kind of recognize that it's just not going to work. And not all vaccines, it's not a panacea for all drugs of abuse. It has to, the vaccines and the antibodies made, the drug and the PK has to match. The PK and PD have to match up. And if they don't, it's not going to work. And so nicotine has a really long half-life. And so that's problematic. And so trying to develop a vaccine against this, I don't know if it'll ever happen. And you know, we're banging our heads into the wall for a long time. And so you go back to the essence of these vaccines. It's just a PK-based method. And so what they do is the antibodies sequester the drug. That's what they do. They're bringing the drug together. And if you had an enzyme, what you could do is not just sequester it, but break it down. So you're basically removing the reservoir. And you think about that, that's a much smarter approach, right? The question is, how can you come up with that? That's not easy to come up with. Another big problem, and something I didn't really realize, but I kind of looked into this over the last few months, is liquid nicotine toxicity. Most people have never heard of it. Nicotine is extremely toxic. It's extremely toxic. And it's not so much for adults, it's children. And so what we see is there's been this huge spike in terms of e-cigarettes vaping, children vaping. The other thing is, when you buy these things, you can buy these, liquid nicotine in these like gallon jars or containers. And they contain like up to 100 mgs per mil of nicotine. A couple mgs per kg will kill a child. And it's flavored, and they're drinking this stuff. And also, there's not a lot of ways to treat nicotine poisoning. So what we found out was I had a Chinese graduate student, and there was some papers reported about bacteria that grew on tobacco plants in China that used nicotine as its sole source of carbon and nitrogen. So they basically lived on nicotine, right? So I had them go out there, and we got some of the bacteria, and we cloned out the first enzyme in the overall pathway, and we tested it out. And my colleague of mine, Karen Allen at Boston, got a crystal structure of the enzyme. We call it NIC-A2. It's a flavin. It's pretty cool. It's yellow, so when you purify, it's kind of easy to purify. You just watch this yellow band and collect the yellow band. Well, you can't see this, but it's the mechanism. It's basically the flavin. It's an oxidative mechanism where it's pumping electrons in. It's causing nicotine to degrade to this structure, which is hard to see here, but this has basically no activity in terms of binding the receptor. So this thing degrades it. It works. It has really good specificity, as you might expect. If the bacteria is living off it, it better have the first step better be pretty good for that. So that's actually important. You can't see those structures, but all very closely related in other possible neurotransmitters it doesn't hit. We had to change it a little bit. Its half-life wasn't long enough, so we've modified its structure a little bit based on the crystal structure to extend its half-life. And we looked at its efficacy. So we chronically dosed nicotine through mini pumps and gave the enzyme. And so this is pretty cool. So we don't see any of the drug around it. We can't measure it. It's gone. So we're not just sequestering it, we're getting rid of it. And we've done some more sophisticated tests in terms of cessation type therapy. So we've looked at withdrawal tests, pain tests, and irritability. And it is a high flyer in all these cases. So I guess I want to make the point is this nicotine enzyme could be of value not only for treating cessation for people trying to stop smoking, but it could have value in terms of acute nicotine poisoning. So I just want to kind of sum up what I've hopefully shown you tonight was that we can get a robust immune response to the opioids and can defeat even high levels of it. We can protect against these breakdown products, which are the real drugs, not heroin itself, which I tried to point out earlier. But it doesn't block clinically useful opioids. We believe the immune system response should be ideal. It can't prevent overdose. We're working towards what we call a heroin street vaccine. We believe we can block these in a singular vaccine. I think they can be long-lasting. And as I told you a little bit about at the end, these monoclonal antibodies. I didn't talk to you about. So a big problem right now that the military is worried about is using these opioids as chemical threat agents. They're high up on the list. They can be aerosolized easily. I don't know if people remember. It was like, I think it was 2003. There was a Russian captive event which took place, I think it was 2003. And what they did was to get rid of the captors, they put carfentanil in the air ducts, which killed the people who were holding the hostages, but also killed like 100 of the people in there. So, yeah, so it's actually, as I said, it could be used as terrorist threats because it's easily aerosolized, these synthetic opioids. And hopefully at the end I showed you a little bit different, so it's not just using antibodies, that we can kind of come up with creative ways to, if we can find a cool enzyme, to try to attack the nicotine problem. So with that, just the group that's involved, my collaborators, many years, Knight has been very supportive in the Skaggs Institute. And if you haven't been out to La Jolla, that's where we're located, in La Jolla. We're up in here. I used to always say this was the last place that Tiger Woods won his major, but since he just won at Augusta, we can't say that anymore. But if you would have gone years ago, there's a special beach down there called Black's Beach. It's, I think, the only beach still in the U.S. that's where nudity is allowed. And actually, you could see Larry jogging down there sometimes with just gloves on and tennis shoes, probably. You'd see him. It's a real sight. That's probably how you got elected as president. You show that, right? Okay, had to throw that in there, Larry, at the end. Okay, well, that's it. I guess if there's some questions, be happy to answer some of them.
So we do have time for questions. As many of you know, we have a procedure for questions. There are some runners with microphones. The microphones have colored foam coverings, and I'll call on you by the color. And when I do, please stand. Please tell us your name. Please tell us if you're a member or not. If you're not a member, sit down. No, I'm just kidding. And then please ask a question. Please keep your hands up long enough for the runners to see you if you have a question. So the first question will be from the person with the red microphone.
Hi, I'm Monica Ahuja.
Oh, you have to hold it very close to your mouth.
Hi, I'm Monica Ahuja. First of all, thank you for a great talk. It's the first time I've seen somebody explaining chemistry in such a basic way that everyone can understand. So thank you for a great talk. My question here is that opioid dosage for cancer stage 1 patient would be different, and cancer stage 4 patient maybe would be different. So how do we determine that, this vaccine would actually not come in the way of giving the right treatment to the stage 4 patient who really needs the high dosage?
Well, yeah, I did allude to that the heroin vaccine is very specific to heroin. You're not going to give a stage 4 cancer patient heroin typically. You're going to maybe give them one of the fentanyls. In terms of if it was one of the fentanyls, that would be an issue. But the point being with the vaccines, they don't last forever. These things, it's not like a polio vaccine. What happens is we vaccinate, they'll stay up for a period of a couple months, and they drop off. And you have to boost them to get them back up again. So it's not protective. The monoclonal antibodies have a circulating half-life of 21 days in humans typically. And so that would be, I guess, a counter to that in terms of, specificity. If someone actually did have cancer and was vaccinated at some point, that presumably within that time frame, they still would be able to take the opioids. It would wear off by then.
Great. And my second question is that once you are doing the mice testing, do you also test that, does it impact the receptive level of pain by the mice? Does that change any kind of reaction? I know that you mentioned that the fentanyl makes sure that it doesn't bind, to the wrong elements. That's why it'll protect, the wrong binding and not affecting anything else. But are you also testing for that it's not going to impact the pain level reception by the individuals who would get the vaccine?
Yeah, it's not going to impact issues like you're talking about. No, we've looked at that in terms of, there's two ways the opioid receptors you can go to. One is pain, the other one is an aesthetic, right? So you can either affect, perception pain, or you can affect cardiovascular. And so we're getting the equipment to look at for the cardiovascular, so I can't tell you that now. But they're both the same arm, so I think it should work in a similar fashion. If that answers the question, maybe it doesn't. Okay.
Black microphone.
Good evening. Hi, my name is Dr. Cheryl Lohman, and I am a member, and thank you for coming here to talk to us tonight. I did my medical internship in inner city Baltimore, and we saw a lot of the opioid crisis before it was had exploded on the news, et cetera, et cetera. I can understand from your talk how the immunotherapy would help with the acute overdose situation. The problem that we saw in the hospital was that when we got an acute overdose in and we gave them supportive care or whatever we did to get them through that, sometimes if we gave them something like Narcan, they would be angry because we had interrupted their high. And as you spoke, you said, people are out there to get the best high possible. And what you're doing, from my understanding, is you're taking that high away. And then my guess would be that they would start to experience withdrawal symptoms. And it's at that point that the recidivism occurs. Is there any way that these vaccines can help with those withdrawal symptoms and the other aspects that come with opioid abuse?
Well, these vaccines aren't, they're meant to be used, in my opinion, meant to be used for people who want to quit taking the drug. So someone who wants to go in for treatment, that's where the vaccines would be useful. So I don't see just vaccinating people who are addicts that have no interest in getting off the drug. That I don't see any value in these vaccines. So we see the value being the people who want to get off the drug, they relapse, which I'm sure you've seen many times in the past, and so we think the vaccines will prevent relapse. That's where we see the most important point. Now the monoclonals, I think would be, again, would be the value there would be for, poisoning, lethality from the drug. The other thing about these vaccines, I think the reason why they work, in terms of trying to break the cycle in terms of the drug is that they don't completely sequester all the drug. Some of that drug's leaking over. And so I think that can actually benefit some case where it's not completely removing it, sweeping it off. So, we'll have to see if that's the case in terms of when we vaccinate, if we're trying to move forward with human trials. We'll have to see if that's the case. I think the biggest problem is not that. The biggest problem is going to be, these vaccines typically, they come up very quickly in rodents within a month. But when we've moved to non-human primates, they take about 3 months to come up to get full value. And that's going to be a problem for an addict. You need protection right away. And so that's where we might be able to use the monoclonal antibody, which gives protection right away, and then vaccinate and hopefully come up. So does that answer your question to any extent? No.
My impression is that
Get a microphone.
when somebody addicted to opioids is relapsing, it's my impression that they'll try to go for a bigger high, even if at the same time they are ambivalent about it and trying to get clean. And so then they'll go try and find, if I might call them this, the rhinoceros opioid dealer. That's just my thought.
Well, it's possible. We'll have to see what happens when we get it out there.
Blue microphone. Please stand up and tell us your name, if you're a member, ask a question.
How close are these vaccines to being mass produced?
What's your name?
Seth?
And are you a member?
Yes, I am a member.
How close are they to being mass produced?
Right now, we were going to push forward with the heroin vaccine, but since we decided to try to make a combo, we're now moving forward pretty quickly with the monoclonals. So we hope to have those in humans in like 18 months. I shouldn't say just me. I have moved this out to a company recently. Academic, it's very difficult to navigate through to clinical trials and what's called an IND filing being an academic institution. So I've been able to license these out to a company. So hopefully they will move it forward.
Red microphone.
Hello, Hello, I'm Marie Burton, not currently a member. The good doctor here sort of stole my thunder, and one of my questions was, where's your market share for this? Who is your target market, and would that be rehab? Clearly, you'd have the same response to it as an addict has to Narcan, that they don't want.
Yeah, you know what, I
Don't want to give
I don't
up
like
this.
that word market share, and the reason being is because the problem I've had moving this forward is trying to find someone who will fund it. And so you're trying to find investors, and people want money back. And I've had tons of parents and people come by to my office and lab, and I don't see us make the people doing this, maybe they will make money off it, but I'm not going to personally take money out of this.
No, and that was perhaps a
But
poor
so the market
choice.
share, I can't tell you. I
Yeah.
don't know where the market share is, and that's the problem. So that's been the last several years trying to get people to invest to move this forward, is because the people now are investing in their personal reasons to do this. They are wealthy, and maybe at the end of the day, healthcare will take care of this or be a provider of this. I don't know right now. That's a clear problem. That's why you saw so many those at the end. I talked about nicotine. Those are all pharmaceutical companies that are trying nicotine vaccines because there is a market for that. Mm-hmm. Okay, so I know people tell me there's a market for this. Well, yeah, there's lots of people out there, but who's going to pay?
Perhaps that was a poor choice of descriptor there, a market share. What I meant was, who is this intended for? Who do you think will be receptive to this? And I'm guessing rehab facilities and,
Yeah.
and that sort of
Yeah,
thing.
that's where that's where I would rehab. I've talked to some people, some people of police and so-called, that they may use that for people who are in jail, prison, a part of a program.
Okay.
Instead of using prison, maybe they go through this type. Because it's one of the things. It's one of the big reasons why we don't get funded on this is because people down here, this place in the White Towers around here, think addiction's a moral failure on the part of the individual versus a brain disease. Okay, so most people feel, well, it's their fault, they need to fix it, versus the brain disease. And so people think it's a brain disease, then maybe we would get some more money and action behind it. So that's one of the biggest things I see right now.
And a quick question, why is the immunity so fleeting? Why don't you get a
question.
T cell response, for
For you.
example?
Because you just don't have constant basically memory with regards to these B cells. It's not the constant memory that keeps it going. They die off. So for the small molecule happens, you don't have the same thing as you do with like measles or mumps or polio.
Blue microphone?
Sorry.
Hi, my name is Dave Griggs. I'm not a member. I'm an engineer, so.
Put the microphone closer to your mouth.
Is that better? Can you hear me now?
A little closer.
I can.
Better?
Yeah,
Yep. Okay. So,
Larry's president, so if he says it's better, you better.
it's for the video.
okay. So forgive me if I kind of ask a stupid question. I'm an engineer. I'm not very good with chemistry. I think you told us that there's a difference between an immune, what do you call it, like a vaccine versus an antibody. I think maybe you also told us there was a difference in the life of the effect of the drug between those two vehicles.
Yeah.
And then to kind of piggyback off what these two women were saying, is this will these drugs have any effect on the I don't know what the right term is, but like the desire to want to use, or like the effect of not
Craving?
like the effect of not having a cigarette, I guess is how I would, the withdrawals, I guess.
Withdrawal, craving? No, typically it won't. But like I said, I think they may have an effect because what they do is they slowly let some of the drug leak out. And so you're kind of just stimulating a small number of receptors, and so not enough. Hopefully they relapse, but enough to potentially not see craving. We don't see, actually, in terms of craving, in terms of the nicotine enzyme, we don't see that. And so if you go and look at some of the numbers and statistics, it's much harder to quit smoking than heroin. And that's really societal effects.
Black microphone. We'll let you not stand, but tell us who you are and if you're a member.
Carl Merrill, I'm a member. So with the enzyme, there are a couple of problems. One is, I presume you're going to give it intravenously, and so it's just going to have a very momentary effect. I mean, it's not like a vaccine where you're going to, unless you're going to put a pump in or something like that.
Well, the enzyme right now, I've engineered so it has about 10 days half-life. And so we're going to try to shoot for about 3 weeks.
And the other problem with an enzyme is they're very often antigenic. So
Absolutely. So it's bacterial. You're 100% right. For overdose, for poisoning, it's not a problem. You give it one shot, it doesn't matter. So that's not an issue. But if you're doing a cessation type therapy, that's an issue. And so what I've done this for several years, and we've immunized it not immunized, but we've put it in animals chronically, and we see a very small immune response. But we'd have to mutate out any T-cell epitopes on it, for sure.
And then the last question is, you keep mentioning sequestering. Do you know anatomically? I mean, is it ending up in the spleen, or where is it getting sequestered when you use your
Well, throughout wherever the antibodies are, throughout the serum, it's being sequestered. Yeah, and eventually what happens is there's off and on, it's either metabolized out, degraded, or whatever, so. It's not like it's activating effector functions or anything like that, right?
Red microphone.
Hi, Hiromi Ono. I'm not a member.
Hold it closer to your mouth.
Oops, sorry. Yeah, Hiromi Ono. I'm not a member. I do work at NIDA, and where we all believe that addiction is a brain disease. I wanted to ask about the drug development state where things are. I know you mentioned that you went to primates from mice, and now it's in the hands of a pharmaceutical company. Was that so? Just where the clinical trial, how close are you to doing a clinical trial on humans?
So I just met with Nora 2 weeks ago.
Yeah, that's great. Yes, she's the director. Yes, so.
Who's Nora?
Nora Volkow.
Yeah, she's
And
the
her team.
director of NIDA, and she is a neuro psychiatrist who truly believes in some of the medication-oriented, treatments for addiction. So yes, so
I didn't just dump this off. I'm still doing this, but within it's taken several years, but finally we found a group that's finally fully licensed it, and about a month ago we started moving this forward, and in talking to Dr. Volkow, she wants the monoclonals to move forward fastest. So that's what we're going to try to do. The ones to carfentanil, fentanyl.
Oh, great. Wow, thank you.
So that's our plan.
Timothy Thomas, I'm a member. On the protein that's going to block nicotine, should I take that? It would be like not smoking.
Should you take that like not?
I mean, basically, I would smoke. If I'm trying to quit smoking,
You're not going to get
smoke.
it. So if you took it and smoked, presumably you're not going to get the effects.
No effect at all. So it would be just like I had successfully quit.
I guess, if you want to put it that way, yeah. Well, you still got.
But I still got the
cigarette in your
problem.
mouth.
Right.
Well, presumably, if you're not getting anything from that, you hopefully would stop
I'll
using
give it
the
up
cigarette.
eventually.
Eventually give it up. That's the idea.
And you think it might last 2 months?
No, the enzyme right now, it's 10 days, but I think I get it to 21 days if NIDA would give me some more money. But yeah, so the enzyme's early days, but I do think it's pretty cool. In fact, when I was out there talking with Nora, Dr. Volkow, she said, well, why don't you have an enzyme for these other ones, Kim? And I go, clever, but not that clever yet. Actually, I think I can design an enzyme for carfentanil, so that's okay.
You can't design a catalytic antibody or one?
I can, I think, for one of them. Yeah, you're right.
Okay, we have a question over here. You can bring the black mic.
David Rosen, lifetime member. And first of all, what's a hapten? Second of all, what if a person's having withdrawal symptoms? It doesn't sound to me like this vaccine will stop the withdrawal symptoms, right?
Right, right. I mean, if you just have withdrawals and just vaccinate, it's not going to do anything for you.
Are there any other questions? Brett has a question. Can somebody get him a microphone? Brett gets the magenta microphone.
Hi, Brett Magrum. I'm a member. I was just curious if you've done any preventative studies on the vaccine, or maybe you've given the vaccine before you've exposed the addictive substance to mice, and have you seen any results where maybe they're much less likely to get addicted if they're exposed to the vaccine prior to the introduction of the drug?
Actually, when we first did this years ago, we didn't know if it was going to work, and so I was working with George Koob, who's head of NIAAA. He had animals that were addicted, and we vaccinated those guys, and that's where we found it worked. So we figured it worked there; it should work otherwise. So that was just to test it out that we did that. Yeah. So we have. That's a good question, though.
Last questions, anybody?
Actually,
If
I
not-
think I'll ask one.
Okay.
I'm Isaac Schomer. I am a member. And my question is, have you tried hooking on a carrier protein to naloxone in order to increase its half-life so it can be more effective against some of the higher half-life opioids?
You wouldn't care. Yeah, you could put it. You obviously could put it on albumin. That's so. With the enzyme, what we do is we put on an albumin binding domain on it, and so albumin has a half-life of 21 days in humans, and so it can circulate longer. So you're right on the button.
Okay, great.
Any questions on the web? Nope. Okay, if there are no questions.
My name is Robert.
Somebody else.
Yes, my name is Robert. I'm not a member, but I wanted to know, where do you get your individuals in phase 1 and 2 testing and such?
We haven't gotten there yet. So we're just, sorry, we've only gone up to non-human primates. So we haven't got any individuals yet.
Any more? No. If not,
Oh. We're done?
let's go and go upstairs.
Oh, okay, yeah.
So before you go, I'd like to present you with a small thank you gift, a framed copy of the announcement of your talk, signed by all the members of the General Committee on behalf of the membership, and a signed copy of Volume 1 of the Bulletin of the Philosophical Society of Washington, now known as PSW, and PSW Science, which explains its founding, lists its founding members, and explains why it was called philosophical, which
Thank you.
really meant science in those days.
Thank you.
Thank you, Kim.
You need to hit the gavel, Larry.
Not yet. Before you go, we have something special. We're going to do a little test of our streaming, of our online voting system, and Jared's going to come up here and help me. So if you can all take out your cell phones. So this is a rare opportunity to violate the Cosmos Club rules. You can all take out your cell phones. Please take out your cell phones. We're going to have you vote on you're going to run the camera.
Tell me where to go. Phil Stockton, PSW.
I did, yeah. Oh, yeah, go to www.psscience.org, and you should see this banner at the top of the homepage. And this is really important because tomorrow night we're going to vote on whether Pluto's a planet. And trust me, our vote is going to be binding on everybody, except people who don't like it. And when you get there, we're going to give you, you'll pull up a form, and you can vote on the question that's asked. I'm going to go to charts. When you pull up the banner, when you click on the banner, there's going to be a questionnaire. And the question will be about what's the most viewed PSW video. Does everybody see it? So you can vote, and as you... That's right, so take the quiz. So if you voted, would you raise your hand just so I have a general idea of how many people voted? Come on. Okay, so it doesn't seem to be reflected in the numbers here. We better do better than this on Monday or Alan Stern will kill me. Ah. Mandar, okay. Is anybody still voting? So we're really confused as a group on what's the most viewed video. So the most viewed video is a physics video. It was David Kaplan's talk, and it's been viewed very close to 100,000 times. The next most viewed video is Nima Arkami Hamed's physics talk, and it's been viewed, I think, 85,000 times, roughly speaking. So physics is very, very popular among people who surf the web. But thank you, that seemed to work pretty well. So tomorrow, we'll find out if Pluto's a planet. And by the way, how many of you think Pluto's a planet? How many of you think Pluto's not a planet? How many of you think Pluto's a dwarf planet? Okay. Well, technically at the moment, according to the International Astronomical Union, Pluto is a dwarf planet. Now, do you know why Pluto is not a planet? The thing that distinguishes Pluto from planets. How many of you think it's size? How many of you think it's roundness? How many of you think it's how far away it is from the sun? The reason that Pluto is not considered a planet is because it doesn't clear the path of its orbit. The IAU definition of planet has 3 prongs, and one of them is that the object has to clear the path of its orbit. And that's why Pluto's not a planet. Now, Alan Stern has an alternative definition, which is really the first 2 parts of the IAU definition, and that would give us about 110 planets in our solar system. So if you're interested in the outcome of this debate or just listening to overall what the reasoning is, assuming there is reasoning. Hey, what happened to my cursor? There it is. Come tomorrow, Monday. Sorry, we'll get to that. Come Monday to Monday's talk. Okay, so before we adjourn to the social hour, we have a few closing items. PSW depends on members and sponsors. If you're not a member, how many of you are not members? Oh, you guys. You guys. Well, if you are not a member, please consider joining. How many of you are members? Okay, if you are a member, if you haven't paid your dues, would you please pay your dues? They're really late. And if you have paid your dues, well, please consider giving us a little extra. Also, if you are a member and you have the energy and you are wholly responsible, you might consider helping carry out PSW's activities. For those of you who aren't a member, this is how you join. It's really easy, you guys over there, right? You just have to go to the home page and hit the join button and pull up the membership form, hit this hyperlink, which will bring up the application for membership. You fill it out, and you hit the submit form. It will bring up the payment page. You make your payment. I think you guys will be elected. Most people are, so you don't have to worry about that. You won't have to be refunded your money, and you'll become a member of PSW Science. Please see Membership Director Lloyd Mitchell up here in the front row, or Corresponding Secretary Robin Taylor, who's obscured by the audio control rack back there, if you have any questions. It's worth noting that PSW lecture membership averages over 100 in person and about 30 on the live stream. Modest numbers compared to popular TV shows, I suppose. But, as I was pointing out, PSW videos altogether at this point, of which there are about 130, have been viewed 250,000 times. And it's over 9 million minutes of viewing. So PSW activities reach a growing worldwide audience. And dues, contributions, and sponsorships are what makes it possible, along with the hard work of our volunteers, who I'd like to thank tonight. So, Ann McQueen, Brett Magaram, Jared McQueen, the inimitable Robin Taylor, our microphone runners, and I guess myself. PSW is a nonprofit educational organization tax exempt under Section 501c3 of the Internal Revenue Code. Contributions are tax deductible to the extent permitted by law and the IRS. All PSW members in good standing can wear the PSW rosette if you wish to purchase one. They're $15, and you may do so at the rosette table in the back of the auditorium. Upcoming lectures. The next lecture is on Monday. It's a Monday. Everybody got that? Not Friday, Monday. And the speaker will be Alan Stern and Ron Eckers. Alan is at the Southwest Research Institute, and he was the principal investigator and prime mover on the New Horizons mission that visited Pluto and objects in the Kuiper Belt. Ron is at the CSIRO in Australia, and he is the past president of the International Astronomical Union and presided over the conference that defined the term planet and reclassified Pluto, demoting it from planethood. This meeting is sponsored by Jean Shaw, a PSW member, in memory of our friend Karen Shaner. The last meeting of the spring 2019 lecture series will be the Henry Lecture, the 88th Joseph Henry Lecture on May 17th. The speaker will be Brian Keating, and he will be speaking on the Big Bang and inflation, glimpsing the beginning of time from the ends of the Earth. Brian is the principal investigator on BICEP 2 and director of the Simons Observatory. He is searching for predicted anisotropies in the cosmic microwave background. He was the principal investigator on BICEP 1, which after a false start did not detect these anisotropies, but he had reported them and then had to withdraw his conclusions about them, and this resulted in his not winning the Nobel Prize, he says, and so he's the author of a popular book called, guess what? Losing the Nobel Prize. It's a very interesting book, actually, and I recommend it to you. This year's Henry Lecture is sponsored by Millamite, Solano & Brannigan, fondly known as MWZB, which is the law firm where I'm a partner. And I will now accept a motion for adjournment of the 2408th meeting of the Society to the social hour. I have a motion in the back. Beat you to it. Do I have a second? All members in favor of adjournment to the social hour? All members opposed? The meeting is adjourned to the social hour.